Well, good afternoon. I am Delaware State Representative Paul Baumbach. I serve the 23rd House District, the west and north side of Newark, and I also serve on the Delaware's Retiree Health Benefits Advisory Subcommittee, and I serve as the co-vice chair. It's chaired by Lieutenant Governor Bethany Hall Long, and the other co-vice chair is State Senator and Senate Majority Leader Brian Townsend. I offer these Facebook Lives periodically to give you an update on the progress of the subcommittee, upcoming steps for it. And with that, how about if we go into it? So there we go. So I'm going to bring up my other screen and let's see. There we go. Okay, you can see. So this is the agenda. Our next meeting is this Thursday from 10 to 12 in Dover. You can also stream it live. And all that information, actually, let me go back. If you Google SEBC, let me try that again. I'm going to type it in. Google. I usually say Delaware SEBC Subcommittee Materials. If you Google that, you will be presented with this page here. And I just put that into the chat. This page here. And it gives you all the information of all 12 past. I'm sorry, it'll give you these three, and when I click on the retiree health benefits, you would come to this page, and then you choose the retiree health benefits, and you can find the 13 past meetings, all the agendas, minutes, presentations, all that sort of stuff. The most recent meeting was last Monday, the 10th, and the next one is this Thursday, the 20th. So, and then you can click on any of these, and that's what I did. I brought up. Let's start with the agenda. It's pretty much the same as the last agenda last Monday. We call to order. We review the minutes. We look at recommendations, presentations. We discuss what our upcoming work is within the subcommittee. We have discussion. We can have votes. Those asterisks indicate that votes are possible. And then we go to public comment, and then we adjourn. So again, it's this Thursday from 10 to 12 in Dover, or streamed via Zoom. So that information is out there, available. And so let's go to, since I last did this 2 weeks ago, I think that was it. I want to go over the, actually here. So this is the presentation from June 26th. Let me see if I can. Okay, that's a pretty good size. So from June 26th, actually the presentation from last Monday's meeting is pretty similar, but still, let's go through the June 26th one, because I think my last presentation was from the 24th, maybe Saturday, the 24th of June. So we often look at, oh gosh, let's back up. The problem is we've got a I forget the numbers now, $9.5 billion projected shortfall between what the state has, I'll say, promised to state employees when they retire for paying for their health care over the years, and how much dollars have been set aside. So that imbalance between the cost of the promises, we'll call that the liabilities, and the money set aside, we'll call the assets. And that gap is projected over the next 30 years or so to be close to $9 billion, which is gigantic. The good news is that's 30 years from now, and we can take steps now that can be in place for the next 30 years to help gradually shrink that and have it be manageable. So there's 3 general approaches that have been discussed to address this. One is funding, putting more dollars aside. So the funding options is one way. The second way is changing eligibility to have either fewer people eligible for it, or for those people who are eligible, have them pay a greater share of the cost. So that's eligibility changes. And the last is plan design. Instead of offering one type of retirement benefit plan, health benefit plan, offer a different one, or a different flavor of the one that you had been offering. And then, but most importantly, there's nothing that says you have to stick in one silo. You can say, I want some of column A, some of column B, and some of column C. So we have been meeting again 12 times already. We've looked at a lot of individual changes, and now we're beginning to say, well, what if we put them together? What would the result be? And so we've got that. This first slide, I think, is the first one that we've had. We had a big aha at the June 5th meeting, which is that these numbers were presented in a way that you could misunderstand what they were saying. As an example, we looked and we were told that 1% funding, sorry, if we set 1% of the budget aside towards this fund, this retirement health benefit fund, that we would get to 60%, 59.8%. We're like, whoa, that's pretty darn good. But what we learned on June 5th was that that is taking into account that we began at 17.8%. So we got this number called a baseline at the top of the table, and we now have figures in there, and it shows that where we are right now is projected, if we do nothing, projected to have about 18% of the gap addressed, enough funding for 18% of the promises. So that 1% of the budget funding is only giving us an extra about 42%. So that was a really important information. It took us several months before we learned that distinction. So I have said on these tapes before, on these recordings, I've been frustrated that it took so long to come out because of how darn important it is. But regardless, with that, it has come out, so we now much better understand the true impact of these changes. And the Governor Carney recommended both, let me see, last fiscal year through June 30th, through 2 weeks ago, and also for the current fiscal year through next June 30th. And the legislature approved both of those recommendations, that we put 1% of the budget towards it. But this line is not for putting 1% of the budget into the OPEB fund for 2 years. It's every year from now on. And the budget increases, 2 to 4% a year based on inflation, things like that, sometimes more, sometimes less. So that amount is expected to grow. Actually, they're saying 3.6% is the expected average annual increase. So it's with that commitment of not just 2 years, but 32 years of doing that, we would close the gap by an additional 42%, bringing us to about 60% of the way. I'll get to this, and I'm going to stay in our discussion as of the June 26th meeting. And if we did 2% of the budget, we'd be 93% of the way. If we did 3%, we'd be over 100% of the way. But you also notice that 2% is not twice the difference. Twice 42 to 84%. Twice it only brings you to 75.4% of a difference between the two. And that's because these things it's not that clean. And one of the reasons is, as we get more funding, the actuaries who set all the math behind the accounting of this, and that comes into their presentations of accounting records, and that's something that bond agencies look at, bond rating agencies look at. Once you get a certain critical mass of funding, then you're allowed to assume that that is going to earn money at a higher rate than if you're just starting out. So we don't get twice that benefit. And then additionally, you go up to 3%, that's nowhere near 126%, which is what that 3 times 42% would be. It's only really twice that. So we put 3 times as much money into it, we're going to get twice the bang out of it. So there's a point of diminishing returns, you'll say, of taking the percent of budget approach. But the most important thing, the most important takeaway is that this table now really does a much better job of presenting this baseline that we're already at. I'm going to call it 18%. And that's because we set aside 0.36% of every employee's paycheck. We don't withhold it. We pay them that, and then we take an additional 0.36% and we put it into this fund. And we've been doing that for quite a while, and we're continuing to do that. So that is going to get us to that 18% rate. So with that, I just want to see whether or not anything is coming up. I am not seeing. Oh, I do have people on. Okay. If you can, someone can enter a comment just indicating that you can hear me. That always makes me feel much better. So that's the first leg of the stool. Funding. One funding way is through 1% of the budget, and that gets us the 1% step that we seem to already be committed to. Will get us to about 60% when you take into account the starting point of 18%. Note that the legislature put that into a bill, and thank you, Henry. I appreciate that. Put that into a bill called Senate Bill 175. That I was the House sponsor of that. Senator Townsend was the prime sponsor. Senator Townsend was the Senate Prime Sponsor. Our other two legislative members, Representative Ramon and Senator Pettyjohn, also were prime sponsors of that bill. That has passed both chambers and awaits the governor's signature. So that's the first piece. Let's go to the next piece. Another way to do it, we're now into eligibility changes. So that was the only funding change approach that we looked at that meeting last month. And now there are 4 classifications that have been presented to us for changing eligibility. The 4 categories, and I'll go to each. Don't rush to anything yet. The first category is, well, if you're a retiree, we're going to be covering you. But if you're a retiree, your spouse, who we used to cover without this, we're going to actually charge you half of the state's cost for the spouse of retirees. The next one is how much you pay in is going to depend on how many years of service you have in. So if you have 20 years of service, if you have 30 years of service, we'll pay all of it. If you have 25 years, 75%. If you have 20 years, only 20 years, you have 50%. So that's what's known as graduated state share. I hate this phrase, but anyway, there's a phrase called future vested retirees. I'm going to take my picture off so you can see the lower left of this table. There you go. So future vested retirees are people who retire way before they're eligible for a pension. So you may work 20 years from age 21 to 41. You're not eligible for a pension at age 41, and therefore you also would not be eligible for health benefits. So pretty much as someone who works for a number of years for the state and then starts a different career for a different employer. That's known as a term vested. And those individuals, which currently can get health benefits in certain circumstances, would be taken out from that. And then the third one is increase the minimum retirement age up to age 60 or 55 if you're, for instance, a retired state police officer. They have a required retirement age of 55, I believe. So with that, those are the 4 categories. Now let's start looking at the other columns because they're very, very important. First is, well, how do we apply this? We already have retirees. We're going to do this to current retirees, and the answer is no. So retirees are not affected by any of these. If we were to adopt any one or more of these 4 eligibility changes, it would change nothing for current retirees. We modeled it in 3 different ways. One is this is only for people who have been working for the state less than 10 years. One is it is only for new retirees, those who haven't even started yet, but those who start 2025 or later. And then the most immediate one would be those who retire in 2025 or later, so just less than a year and a half from now. So as you would imagine, the one that would, I'll say, save the most money would get us furthest along is the Model C, retirees who retire in 2025 and beyond. Now, here's that thing I was talking earlier. It says, if we do that, reduce spousal share 50%, and we do it for new retirees 2025 or later, we're going to close the gap by 20%. Well, no, we're not. That's only 1.7% ahead of where we already are with the state funding, the current benchmark, where we are, our starting point. So we were looking at this before and saying, we'll just take 1 or 2 of these eligibility changes and we'll get 30, 40% of the way there. That's great. We can do 60% with the 1% of budget. Game over, taking care of it. It's all done. Nope, these things are getting you between 1 and 3.5% of the way there. Actually, less than 1% to 3.5% is it 3.5? Nope, 3%. So these are really small impacts as far as the percent funding, getting that, closing the gap by 1%. So that, frankly, reduced the attractiveness of these eligibility changes significantly to several subcommittee members, including myself, when we saw the real limited benefits of it. So no final answer in there, but again, I want to stress a few things. We're only exploring changes to apply to new retirees. Nothing changes for current retirees. And these are the 4 categories. And we found in late June that no, this isn't changing things by 15 to 20%. This is changing things by 1.5 to 2.0%, really much, much smaller impacts for these changes. I will say politically, legislatively, if this is something that's going to be done through legislation, this is something that can raise a lot of frustration by future retirees. And you say, to what benefit? How much benefit are we getting for the people who are getting upset about this? These are not really significant, in my mind, significant savings to warrant some of the changes here. So this is something that's probably good to maybe do one or something like that. But frankly, I think doing it, for instance, for new hires or even those who have been working less than 10 years, I think that's better than those who are more palatable, more, I'll say, passable if there's a legislative step here, than the people who retire just a year and a half from now. So I'd be leaning towards the Model A or Model B for whatever of these we end up selecting. Keep in mind, I'm one of, I think, 15 members of the subcommittee. I'm one vote out of 15. So, I don't rule this thing by any stretch. I'm just one voice. So eligibility changes, pretty darn small, 1.5% to 2%, 0.5% to 2%, to 3% is the max amount. So not game changers there. Okay, benefit design, plan design, whatever. So we spent some time in the past 12 meetings looking at health reimbursement accounts. That's one where each month or each year you are given a flat sum of money from the state. We modeled it with $5,100 a year for each eligible member. And then we increased that by some annual amount. We modeled 2% and 4%. And we again look at how do we grandfather this. This does not affect current retirees. This is only for new retirees. And we've got the same three models, depending on hire date, retirement date, etc. What you find is that you are getting I'm going to say a delta, a difference, a forward benefit, if you will, from 8 to 13% if you do the 2% one, the 2% HRA, and you get zero benefit. In some cases, it costs you a little bit if you use the 4% amount. Now, what does 2% or 4% matter? And how does this, how do I look at this? We have seen analysis of this in previous meetings of HRAs, that if you increase it by 2%, medical costs increase more than 2% over the past decades. It's been much higher. So what you find with an HRA at 2% is you'll be fine. All things equal, you'll be fine in your first 20 years of retirement. But if let's say that you do retire at the traditional 65, and your expenses will be less than that $5,100 they give you the first year and $5,200 the next year, with the 2% increase. But that 2% is not going to be enough to keep up. You'll build a balance in the early years. You'll suck down that balance in the later years. And if you live a long time, or if you have notably higher than average health costs, that HRA will be emptied in your likely your 80s, certainly in your 90s, and leave you a little bit up a creek. So that 2% for me is something that I would not be comfortable supporting. And then the 4% doesn't do anything for the problem. It doesn't narrow the gap at all between the promises and the assets to back the promises. So I don't like this one because of what it does for older retired people who live longer and who have higher health costs. I don't like this one because it doesn't address the whole reason we're here in the first place, which is addressing the funding shortfall. So I don't like either of them. We haven't, as a subcommittee, yet voted on this, but I would be supporting getting this off the table so we can simplify what we look at. Okay. Next one. Now, this only, nope, well, let's go one at a time. So this is pretty darn nice, clean thing. This looks at, let me use terminology. If you're 65 and older, you've paid into Social Security, you've paid into Medicare, you are eligible for Medicare, which covers roughly 80% of your health costs in retirement, age 65 and beyond. Many people, if you're not employed, if you didn't have an employer who promises retirement health benefits, you will go out and get your own Medigap plan. So that's a term often used, a Medigap supplemental plan. So it goes and it covers much of that last 20% of your costs. For Delaware retirees, in the past, we have done exactly that. We've offered a Medigap supplement plan. The current one that we provide from Highmark Blue Cross Blue Shield, it is called MedicFill, but let's use the generic term of a Medigap supplement. So what this says is, currently, depending on when you retire, you either pay 0% of the cost or you pay 5% of the cost. And the state either does 100 or 95%. Well, this says, well, how about for future retirees? We boosted so the state's only paying 90%, and the retirees paying 10%. And the second line down is, what if the state's paying 85% and the future retirees are paying 15%? So it would triple their cost, but it's still a low cost in there. And what we found is that it does between 0.5% if you double it to 10%, and about 1.5% if you triple it to 15%. So okay, again, it's a change without a big impact on the bottom there, on the funding amount. So okay, but that's another way we can change the benefits and do a little bit of addressing the gap. Not a big game changer there. Okay, now just to get people's blood pressure rising, at the late June meeting, we also said, well, just to be complete, let's look at all options, let's look at everything, all possibilities. What if we did something like the state was proposing last year and offered a Medicare Advantage plan to new retirees? Okay, not current retirees. No. But new retirees have a chance of getting. They don't have a chance. They have Medicare Advantage. That's the only plan offered to new retirees, and it could be, again, based on those who retire after 2025, those who are hired after 2025, those who are hired after 2015. Nothing changes for current retirees. New retirees, depending on which of these models, would only have Medicare Advantage, and they still are paying 5% of the cost. Well, that is going to get you about a 5 to 8% increase in narrowing the gap. That's important. This is not 0.8%, it's 4.8% or 7.8%. So it's a bigger amount, but it's also not a game changer. It's not 30%, not 50%. It's single digits, 5 to 8%. If we were to have all future retirees with a certain grandfather date in there, have only Medicare Advantage with a Medicare supplement plan offered for all current retirees, everyone who doesn't get hit by this. Okay, good to have some numbers on it. If it was 80% to make this change, that might be different, but it's less than 8%. So, okay, let's take that in context. So what happens? So one more funding option that we've talked about a little bit in the subcommittee is, I said, you remember the baseline is 0.36% of all payroll goes to this fund. Well, what if we boost that to 1%? Well, that brings it up by 7.7%. And that might even be truly additive. So maybe if we brought it from 1% to 2%, that might more than double that and get you up maybe 15%. These, that alone is better than the best that Medicare Advantage change can do. I like the sound of that. So, okay, good. Let's keep that on the table. I like that one. That's gonna. Now let's back up. Who's paying that? And frankly, ignore this right column. Please ignore this right column, because taxpayers is sort of saying, well, the only one who's pays it are these taxpayers unrelated to retirees. Retirees are taxpayers. So that column can easily be misunderstood. Ignore it. Who pays if we change this funding percent from 0.36% to 1%? What's this mean? In our budget, we're going to take, a big part of the budget is our state employees, okay? And every dollar that we give to state employees, and it's probably $1 billion or more, we need to get 0.36%, 1/3 of 1%. No, actually, we need to up it to 1%. We're going to increase it by 2/3 of a percent. 2/3 of a percent of a dollar is next to nothing. 2/3 of a percent of $1 billion, serious dollars. And those are dollars that can't go to other things that we want to spend money on. Additional counselors in our schools, additional police officers on the streets, additional, whatever it is that is you care most about that the state does, this is going to take some dollars away from that. So that's going to limit the budget, just like putting 1% of the budget meant that's $50 million a year that we can't put towards other things that we'd like to do within the state government. So it's it has a cost, but it has a measurable impact, close to 8%. Okay. Now this one is a combination. So this says, what are we going to do here? We've got we're adding a Medicare Advantage choice. We are increasing the share. We'll get to the details in a second. And are we doing anything? No, that's all we're doing. So what we're doing in this case, we're leaving that, of course, that baseline. And we say, okay. And keep in mind, if you're a current retiree, no change. You get your Medicare supplement with a 5% cost or 0% cost based on when you get in there. But what this says is, if you've got less than 20 years of service at the time you retire, you're going to have to pay 15% for your Medicare supplement plan, or you can accept the Medicare Advantage and only pay that 5%. So you have a choice between both of them. You have to pay a little bit more to get the Medicare supplement, or you can get the Medicare Advantage for less. And this assumes that 90% would choose the Medigap plan and only 10% would choose the Medicare Advantage, because you have to make an assumption if you're going to model it. And it was only modeled for future retirees, those who retire 2025 and beyond. And what you see is that this combination gets you 2.2%. So having that choice with a pricing difference to the future retiree between the two plans gets you at a 2% narrowing of the gap between promises and assets. First combination. Okay, let's look at this combination. So this again is obviously somewhat more complicated. Both plans. So we've got a Medigap plan and we have a Medicare Advantage plan. Based on your age, again, current retirees, they get Medigap, 5% cost or 0% cost depending on when they retired. No change. This changes nothing for current retirees. But those who retire after January 1st, 2025, if they are 60 or older, then if they're 65 or older as of 65, all current retirees after if you retire on or after 25, you're at least 60 years old, but not 65. Okay, so you're going to pay 5% for either your Medigap or Medicare Advantage. If you're less than 65 as of January 1st of 2025, then you would end up paying 30% of the cost, not 5%, but 30% of the cost for Medigap or 5% for Medicare Advantage. If you're 5 years younger than that, between 55 and 60, you would pay 55% of the cost for the Medigap or 5% for Medicare Advantage. And it gets down to the point, if you are less than 50 as of January 1st, 2025, and you retire, you would pay 5% for Medicare Advantage or the full cost to the state of the Medigap plan. So what does that do? That gets you about 5% of the way. That's what we've got there. So this is really a plan design. It's not really an eligibility one. Well, it is in the sense that we've got a higher cost by the member who pays into it. So that was presented. Now this one, look at each one. This is one that truly is a combination. So it says we're going to do 1% of the budget. We know that gets us another 42%, gets us up to 60. We're also going to have the retiree pay more to have their spouse covered. They pay 50% of the cost there. But we're only going to be doing a Medigap plan. We aren't doing any Medicare Advantage here. So what this does is this gets you up to 64%. We were at, remember, 59.8. We'll call it 60%. Gets you an extra 4% compared to just doing the budget. And the difference is that, again, we're doing a Medigap that was sort of our baseline. But we're charging if you want to cover your spouse. Again, this is for future retirees. People who retire after 2024 pay 50% of the cost for your spouse. The state pays for you as a retiree. So that gets you 64%, a delta, a difference about 4%. That was what was presented June 26th or thereabouts. I just want to go quickly over the last few things. Here's the table of what's known as the OEC, other employment costs, so that when the state is paying an employee a set salary, say $50,000, then they also set aside so much for their pension, disability. They set aside money for, in case in the future we increase state retirees' pensions. We pay this 0.36% specifically to this fund. And then we also pay for towards just the cost of all employees and retirees, actually just retirees for their health care costs. And then also all the Medicare, Social Security, workers' comp, unemployment insurance pieces. So together, that's about 32% of that $50,000 that we pay. The employee gross, we have an additional $6,000, depending on the election, it says, of these other costs, these other employment costs. And I don't want to go to that one. That's just ugly details. So that was, we're going to rush through the next one, but that was the June 26th presentation. So brings us to July 10th. The presentation is near identical, so we'll go through it faster, but I do want to talk about a few things. So the same thing, 1% gets you an extra 42%. Start at 18 plus 42, you're at 60% just by doing the 1% of the budget forever. And that's 60%. We're getting there. Not as far as we want to go, but getting there. Eligibility changes. We're reducing, or in some cases, having you pay a little bit more, or reducing who's eligible, or when you become eligible for retiree health benefits. And the total changes go between less than a little bit over 0.5% to 3% of narrowing the gap. So make some changes depending on when it's grandfathered. The impact is in the low single digits. So that's all the 4 different eligibilities on there in isolation. So plan design HRAs, we know they save money in the high single digits amount. If we have it increased by 2%, which has been shown to not be good for everyone. And if we increase it to 4%, which is a much better rate, it doesn't help us in our charge. So I would say let's ignore it. Let's move on. So keeping what we're doing, having something like MedicFill, a traditional Medigap program that's actually the one that we have, has very low copays, and it's a very low out of pocket, very, very low ones. And that, for whatever reason, makes things slightly better than what we have right now, even though we're just talking about doing exactly what we do right now. I'm sorry. No, this does increase that retirees will, future retirees will pay up to 10%, or will pay 10% of the cost as opposed to 5 or 0%. That'll get you an extra 0.5% or so. Or if we go up to 15%, it'll get you, 1.5%. So sorry, I missed that part. So increasing the share of the premium that future retirees pay to 10% or to 15% gets you 0.5% or 1.5%. Okay, remember we saw all this stuff. If you do Medicare Advantage, it gets you around 5%, a little bit more if you implement it faster, starting in 2025. This is only for future retirees. It would force future retirees to have a Medicare Advantage plan. That'd be the only one that would be offered to future retirees. Okay, remember this is all, we've seen this before. We increase the OEC rate from 0.36 to 1%. We get an extra 7.7%. Good. Don't go further here. We'll get to that later. If we go to a Medicare Advantage plan, am I doing that right? Let's see. So this is for the future. And this says that you're going to increase the share from 5% to 15% if you want to keep your Medicare supplement. This is for future retirees, future retirees only. No change for current retirees. Future retirees who retire after 2025 will pay 15% if they want to have a Medicare supplement, a Medigap, or the normal 5% to get the other option, which is Medicare Advantage. And then we also have the one where, depending on how old you are, you pay either 5%, 30%, 55%, 80%, 100% of the cost of the Medicare supplement, the Medigap, or you can get the Medicare Advantage for 5%. All future retirees only. Sorry, the one back here gets you an extra 2%, 2.2%, and then the one down here gets you an extra 5%, where you're really charging, especially future retarees, 10, 15, 20 years out. You're requiring them to, if they want the Medigap, to really pay up for it, pay half or more of the cost of that. So that's another scenario. So what do we got here? This is a combination where we've got the budget. So that's an extra 42%. We reduce that. You have to pay 50% for your spouse to be covered. No Medicare Advantage, and that gets you up to 64, which is about an extra 4% or so over what we're looking at for just the 1% funding. Okay, again, nothing really new here. Here's a new one. This one says that we talked before going from 0.36% to 1% of employment costs. And this one has it increased by 1% every year until it reaches 10% or until it reaches the required actuarial contribution. And well, actually that part's not in there, I don't think. Nope. So it just goes up to 10% and stays there. This gets us beyond 100%. So if we just keep saying percent of payroll, increasing percent of payroll goes into this fund every year and just gradually increase it by 1% a year, we'll hit the ball out of the park, grand slam, over 100% covering those promises, 130% here. So what we're going to do in the future, I think you've seen exactly that table, and that one I keep it not letting you see. So I don't think it's all that important. So what do I want to talk about about the meeting we had last Monday? You'll notice that in the late June and the July 10th meeting, there has been a real two things. One is you'll notice Medicare Advantage is showing up, not showing up as often with only Medicare Advantage, but rather showing up as it's a choice. It's something that's being put out there as a choice, and it's priced to be a favorable choice in that it's priced less than if you, as a future retiree, if you choose it versus a Medigap. The Medigap, you're going to pay more to get. So that has been presented much more, I won't say forcefully, but much more regularly in the last two meetings. Let's use our little Wayback Machine. And if you remember last August and September when the state was saying, oh, Medicare Advantage, we're making you have Medicare Advantage. And people saying, I want my Medic-Fill. I know my Medic-Fill. I know how it works. I'm so comfortable with it. I don't want that change. I hear some horror stories. Just let me keep it. I'll pay the difference. And now I'll say that was and you can argue that was a statement of desperation because many people really didn't want to make that change. So what is being presented here is, hey, we heard you. We're going to give you what you were asking for back in August, September. I can argue that was almost a year ago, and a lot of the world has changed during that time. We've had 12 meetings to see a lot of information, to hear from a lot of members of the public about this and about their concerns, for instance, about Medicare Advantage. And yet that is what's being presented a lot to the subcommittee is, what about an option where, sure, you can have Medic-Fill, or a Medigap, but hey, let's also offer Medicare Advantage. It's a choice. What's a choice? No problem there. And I know that's I'm being a little exaggerating in it, but it came up enough, and frankly, I got a little bit annoyed July 10th, and I think twice I said, choices are good. It's good to have choices if the choices are good. If one of the choices is bad, a choice between a good and a bad thing isn't a good choice. So I get that almost a year ago, we had people saying, yeah, I'll pay. Just give me the ability to pay into a Medigap plan. The state is now saying for future the state isn't saying this. The subcommittee is being presented with options that include a Medicare Advantage. And for future retirees and different grandfathering schedules, future retirees would have a choice of both. But if they wanted a Medigap, they would have to pay more. And if they wanted the Medicare Advantage, they'd pay less. So that's being pitched. It does indeed save. It saves in the single digits, say 2 to 5% range. It's not a game changer in any stretch, but that is being presented a lot. So that's the first thing I want to mention about the last two meetings. The second one is about this past meeting. The July 10th one is Secretary Rick Eisenberger, who heads the Department of Finance, presented to me a kind of frustrating uh, description that what we've been spending 5 months on, of looking at that gap, that $8.955 billion gap, and focusing on what percent we can narrow it, and really focusing on that percent. Can we get towards our goal, 75, 80, 85%, somewhere in there? That's what the first meeting I said, hey, that's what I'm looking at. I want to address that gap. And how far do we need to go? And we heard, get 75, 80, 85% would be great. So then on the 10th, the secretary said, well, that's important, but that's not everything. There's more to it. And what he was pointing out was that the cost to the state of everyone's healthcare, but specifically the retirees' healthcare, and I don't mean just Medicare-age retirees, all retirees, their cost of healthcare continues to rise at a very high rate. So yes, if we address that percent, get it up to 75, 80%, we'll be getting that. We'll be putting a whole lot of dollars in there, but that's not going to that's going to require growing portion of every year's budget for the next 30 plus years and beyond, frankly. But there's also that year's costs that are also going to be growing. And if we don't make plan benefit changes, if we don't make eligibility changes, then we have an additional factor that's been invisible, has not been reported to us in our subcommittee, that's going to be growing, and introducing another element of the challenge that our subcommittee is tasked with. But it wasn't mentioned until early July. So it's an important element, but it wasn't important enough to raise in March or in April or in May or in June. So this is the second time when I've been very frustrated at one of our public meetings of the subcommittee. The first one, that baseline was not being presented as there. So that these, for instance, these eligibility changes that were going to get you 19.5%, we're not getting you 19.5%. They were getting you 1.5% over the baseline, which was 18%. So anyway, I want to go over that. I want to go to questions. I know I only have a few people on and a few questions. Thank you, those of you who are on. Anne-Marie asks, knowing MA is a terrible plan, the state would be risking people not wanting to work for them. Anne-Marie, good point, but I want to be even-handed. So let's talk about a few things. One is, I have zero question that in your mind, Medicare Advantage is a terrible plan. I will say that I'm not that far off from you. But we have 15 members on the subcommittee, and not everyone on the subcommittee feels that MA, Medicare Advantage, is a terrible plan. So keep that in mind. Now, the second part of your point is that if the state were to provide MA, especially if the state were to have it be the only one that either you could choose or that you would choose because the other one's too expensive for you, pointing out this would risk people not wanting to work for Delaware. Great point. And indeed, the subcommittee has been focusing on what are the both intended and unintended consequences of decisions we make. So this grandfathering really matters. If we have a hard deadline of you're going to get the new rolls as of January 1st of 2025, we risk a big exodus, a big wave of retirements in late 2024. We are already very short on employees. We have at one point, I think, close to 20% openings in some of our departments. Terrible, terrible situation. If we are encouraging our existing state employees to retire, to get out of these changes, these coming changes, that makes things really bad. And also, if a new applicant, a potential new employee, looks and says, geez, when I retire, you're going to give me Medicare Advantage? I've read some of the crappy articles on this thing. I don't want that. go to this other place that offers something better, something that's not Medicare Advantage. Indeed, that's an important consideration. I would point out that we have seen that surrounding states typically offer Medicare Advantage as a choice, along with a Medigap plan. In addition, I believe that all 3 counties have Medicare Advantage either as their only plan or as one of multiple plans. So it's if that were to continue, I understand that by like next year, half of Medicare eligible people will be using Medicare Advantage. It's been growing. So that concern is a real concern. If indeed Medicare Advantage keeps growing, then that becomes a lesser concern. If Medicare Advantage stops growing, so let's use the hypothetical that what many people in Delaware have been learning the past 12 months is the downside of Medicare Advantage, the concerns raised by it. Some various academic studies have come up on health outcomes, in some cases being worse for Medicare Advantage populations. That can end up stopping the rise in Medicare Advantage, and you start seeing a decline of it, or at least no more than it doesn't keep going up. And if that's the case, your point is a very good one. That hypothetical case, that's a good one where, as an employer, we may have an edge by not having a prospective new employee see that they're going to be the only retiree health benefit they would get is Medicare Advantage that has a neutral, if not negative, reputation. So, important point. It'd be easier if our obvious competitors, such as our surrounding states and our embedded counties, weren't also in a Medicare Advantage friendly position. So that's why I say there's a lot to that. I absolutely understand the underlying issues. Second point is Medicare Advantage plans must have 26,000 Advantage or they'll pull out. So why would you offer it as a choice? So that comment, Henry, is based on statements made at public hearings this time last year, last August, September. We no longer believe that is the case. So we were told that we were. I think it was at the Goldie Beacom meeting that a lot of people from Newark went to or caught streaming. I caught it by streaming, and was that the one I was in one in person, maybe the one at the senior center, and the question was, well, can't we just offer MedicFill, a Medigap, and then also offer Medicare Advantage? And we were told, oh, Medicare Advantage only works if you have everyone in there. You need all 26,000 people, all 26,000 retirees and other covered individuals in there to make the math work. We were told that explicitly. I agree with you completely. Not accurate. We have since learned that we said that, didn't really mean that. We've got, for instance, Kent County can have a Medicare Advantage. It certainly doesn't have 26,000 employees. So there was perhaps overstatement made during some of those public meetings. So I do believe that Medicare Advantage can be quoted for a subset. And what was modeled here is, 10% of future retirees would choose Medicare Advantage and 90% would choose a Medigap plan. And our wonderful consultants are saying that is indeed possible. It may be there'd be an extra 5 or 10% cost versus if you had the biggest pool. Actually, if we had a really small pool of Medicare Advantage, it may indeed really reduce the cost advantages. But we don't have any numbers to say it is or it isn't. But we are led to believe that we would be able to request a proposal that had much smaller pool, Medicare Advantage, and then presumably a larger pool for a Medigap plan. Okay, next point. And thank you for your question. Please keep questions coming. I really appreciate it. It worries me that the elected or appointed officials are not knowledgeable and aware of lawsuits and problems with Medicare Advantage. I get that. So a few things. New York, gosh, I wish I knew if it's the city or the state. One of them was doing the same thing that we did last year, and a court case came up. And as a matter of fact, some of the same people involved that lawsuit in New York have assisted the litigants, Rise and others, in taking the state of Delaware to court. They just got a favorable judgment, favorable decision made recently. Thank you, it's New York City. Appreciate that. They got a favorable judgment decision recently. I don't know if it's final or if it's, but it was saying that indeed, it's not. I'm not going to say that it was saying that Medicare Advantage has problems. I think the suits have been saying the process used to switch from a Medigap to Medicare Advantage, that process violated city state rules. Furthermore, and this is, I think, what a lot of involved retirees will say is, we were misled. We were told, oh, it's the same thing as what you had, just a little bit different, but really the same. And the judge, for instance, in Delaware said that was not accurate. And I imagine the same thing happened in New York City. So it's not that they were saying Medicare Advantage is bad. They're saying it wasn't presented fairly, accurately, honestly. And in Delaware, they're saying that the steps, that the change was large enough that there is a higher level process you had to go through, and we didn't. So that's what this centered around. Not that Medicare Advantage is good or is bad, but it's different, and it was different enough that a different process should have been followed. Again, I get you, and I get what you're saying. I think that members of the subcommittee, so elected and appointed members of the subcommittee, have certainly heard. We've heard nonstop. I've had 35 emails in the past 3 days about Medicare Advantage and not wanting it as even an option for future retirees and certainly for current retirees. And I think that every subcommittee member got at least those 35. So I think we are hearing it. But anyway, it's there's a lot going in there. Roger, I'm not sure I understand the other underlying growing expense the secretary raised. I understand there's an existing $8 billion shortfall and projected future shortfall. Is the additional issue medical costs growing more than core inflation? Sort of, yes. So Roger, great question. And what Secretary was referring to is that, as I understand it, because frankly, we didn't spend much time on it on the 10th, and that also there's a lot of things that disappointed me on the 10th. One of is, if you bring in a bombshell like the secretary brought up, I would have liked more time to dig into exactly what are you talking about, exactly what factors go into that, and what are you suggesting that the subcommittee do with that? Define what numbers we need for everything we're considering, define what the goal is of that number, and let us measure to see the impact on that number for each of the different combinations we're looking at. That was not done. My best understanding of it is that if you go to the OEC, there's this PAYGO element, and here we go. Let's go up to this guy again. So I know that towards the end, okay, let's try it this way. Way at the end, we've got this PAYGO element. There we go. So we take 9% of payroll and we put it towards PAYGO. What the heck is PAYGO? Yes, we have people pay into. That's the current cost of retiree health benefits, and we take 9% of payroll, which is, again, payroll's big, $1 billion plus, yeah, and we put 9% of that each year, that year, towards the current cost, not towards future retiree health benefits costs. That's what OPEB is, future stuff, but to that year's cost of delivering healthcare to retirees. I believe Secretary Geisberger was saying that number, just the nature of the beast is medical inflation is at this cost, is at this increase, and government budget increase is less. And if we don't do something to bend that down, then putting 1% of the budget ain't going to do it. That 1% of the budget, yeah, it looks great now, but 1% of the budget 30 years from now is going to be 1% of the budget is going to be a smaller proportion of retiree health benefits than it is this year. So we either need to have an expanding funding source, or we need to shrink the rate of increase of retiree health benefits. I get it. Would have loved to have heard it in March, and had the subcommittee be looking at it every meeting and with numbers. I get it. I think that's what he's talking about. I think the issue is his concern. I think the secretary is raising that retiree health benefits, when you look at what each year's portion of the budget, even with increasing the funding, which is absolutely beneficial, will still not stop the growing slice of the pie that retiree health for that year is taking out of each year's state budget. I think that's what he's talking about. I hope that makes sense, Roger. So you're not losing your Medicare. Well, so Anne Marie, you raise things. I get it. I do not know word for word what they said, but I think that her point is they lied and said we were not losing our Medicare. Medicare Advantage is Medicare. It's Medicare Part C, if I remember correctly. It's not traditional Medicare. Clearly, it's not traditional Medicare. Clearly, it's administered by insurance companies as opposed to CMS, the Medicare system, for 80%. The Medigap is run by insurance companies, same as Medicare Advantage is. It is a cousin. It is not a twin sibling. It is Medicare, but that's definitional, if you will. Medicare adopted, I think, 1998, 25 years ago. But it's only recently been really growing in its use, in its adoption. And I think a lot of that is just the economic lower upfront cost. And is that, penny wise, pound foolish? Yes, you can save some upfront, but you may pay for it later on. That's the concern. That's one of the big concerns. And again, the lawsuits, I think, are largely, they're not really focusing, they're not arguing that Medicare Advantage just plain stinks. They're not. They're saying that the process on changing retirees' health benefits to Medicare Advantage were not done in a proper manner. And we've got laws and regulations that say if you're making a big change, you have to go through these steps. I'm not just saying, oh, I don't like it, so therefore I'm going to. No, seriously, we have rules. If you're going to make a big change, you got to go through a big change process. And I think the lawsuits are generally saying you didn't do that. Anyway, Roger, Haley's solution on the combined increase the OPEB fund contribution and an increase in percentage paid by all retirees. Yeah, I think so too, Roger. Perhaps there's a need to look at every 5 years. So, Roger, thank you. Great points. I do indeed think we need combinations. I think I look at the simplest one is we're going to use round numbers. We get 18% by changing nothing. That's nice. Baseline's 18%. We get another 42% from 1% of the budget that we've already put in place. We need to commit to do that forever. That'll get us 60%. Another 42 brings us to 60. We bring the OEC number from 0.36% to 1%. That's another 7.7. We'll call it 8. Be nice and round it up. That brings 68%. We bring it up another full percent. We should get somewhere in the order of 10% more. 68, 78. Man, we're pretty darn close. Maybe do a little spousal thing, a little, one of those 4 eligibility pieces, another 2%, gets us up 75%. I think we're spitting distance there. And then your point of checking every 5 years, absolutely right. These are things that we should be checking regularly, and seeing what are those rates of increase of the budget of health costs, and if we. It comes down to we've got different political views. It's not political views. It's more of, I don't know what the heck it is. But there's a theory. There are those who say, if you know what you're paying and you have more skin in the game, you'll use a service more responsibly. So this is by having co-pays and higher premiums, you'll be more selective of when you go to the doctor, et cetera. Other people say, well, when you go to the doctor more often, you're going to avoid those emergency rooms, and that's where the real big costs go. You have more preventative medicine, so you'll catch it before you get into full diabetes and you have a much higher diabetes cost, or you've got, liver issues, all these things. If you catch them earlier, you save a lot of money. So it's better to make the service available and accessible at a lower entrance cost, and you'll save money down the road. And others say, no, we need people to be paying along the way, and then they'll be more selective of, I'm not going to go, 3 times a year to see the doctor for a checkup. I'll go once a year, kind of thing. And it's not political, but it's a global perspective. It's a world order thing. And, we've got a range of people in the subcommittee with different views on that. So I think there is that concern of, if we can find some way to get everyone to say, we're in this together, let's see how can we keep the cost of the program down, whether by we pay more into premiums, we pay more in from the budget, from the OEC. We wait a little bit before we rely on it. We wait until closer to 65 instead of taking it at 60. Different things like that. Those ways can all combine. Failing that, we're going to need to do harsher measures. If we can collectively, keep things growing at a lower rate, then we can check in 5 years and say, we're on course, no changes, no problem. But I think you're absolutely right. We should be checking this every 5 years. I think 5 years is a good amount of time, and say we're on, or we need to make a course correction. It's very good. Thanks, Roger. Okay, Henry says they get $9,000 a year from every one of us. We still pay into Medicare, and they control the water down. They're trying to water down they control and water down the coverage. Wish I could read. As explained to me by a Medicare representative. Bigger point, and I don't want to be guilty of what I've criticized others of doing, but I think there's a gigantic point that we've not addressed well enough in this subcommittee, and partly it's because it's a little bit outside the subcommittee. Subcommittee is retiree health benefits, okay, and it's really is focusing on Medicare age, because going to Medicare Advantage has no impact on someone who's less than 64 years of age. Okay, so it is. I'm going a little bit off the reservation. I'm going beyond the scope of Senate Bill 29 that established the Retiree Health Benefits Advisory Subcommittee. The whole level of premium setting for current employees, sub 65-year-old retirees, and 65-year-old plus retirees is insane. It's not. In a normal world, you would have it tied to the costs of each of them. Medicare age retirees have one great benefit, which is 80% of their health costs are covered by Medicare, not the state of Delaware. Excellent. Now, why is it covered? Because they've been paying in all their lives, as have their employers, state of Delaware, in the case of state retirees. So they paid into this. They also pay in each month out of their Social Security check. And together that pays essentially 80% of their health costs. So the state's just responsible for 20%. Nice little piece. Only one little problem. Health costs rise with age. And your, by definition, oldest age participants are those who are 65 and older. So the Medicare age population has the years with the highest costs, but the state's only paying 20% of that. But if someone retires at 51 after 30 years of service, they started as a teacher at 21, worked 30 years, 51, they're getting their health benefits. Those next 14 years, the state's paying 100% of it. Medicare is not there to pay the first 80. So that's a big piece. But they're 51, and their health costs are probably a lot lower than a 71-year-old or an 81-year-old or 91-year-old. So, but the amount that we have each of these three subpopulations pay, or we attribute, we call it premiums. It's not really a premium, but it acts like a premium. The amount that we assess for those three populations are not related to the underlying costs. I don't get it. We should be noting Andrew's point that that the amount for people 65 to 70 that the state pays is pennies compared to what they call the premium. But what a 95-year-old retiree costs the state is much more than what the state is, quote, charging in the premium. Using one premium for a 66-year-old versus a 96-year-old is insane. and assessing the same premium for a 64-year-old where you pay all of it, or a 66-year-old where you pay 20% of it, is also insane. So the whole approach that the SEBC takes and has always done it, apparently always done it this way, makes no sense to me as an outsider. And I've only been in this area for 12 months. Really, it was outside my visibility until this whole thing came up in June, July of last year. It makes no sense, and I think that's part of the problem. So I don't know the solution, but there's stuff that we're looking at in the subcommittee, and there's stuff that should be looked at by someone. So sorry to ramble. Geez, we're already over an hour. I guess that's either you guys are letting me ramble, or you've got great questions, or a combination. With that, I think we're good. Please join us if you can. If you go back to that one page, let's pull that page up, and we're going to go to that one. There we go. And do keep in mind, we've got meeting recording. You can always listen, I think even watch the past meetings through the recordings. It may just be audio. I haven't checked myself. Other people do. So, even if you can't make it at 10 to 2 on Thursday, a lot of people are kind of busy that time. Don't have to be there in person. Don't even have to stream it. You'll be able to get to the recording as soon as it's available. I don't know how long it takes to come up. And if not, check my next Facebook Live on this. I do post all this stuff on YouTube for those who don't use Facebook. I got to say, I'm very appreciative of comments of appreciation. I don't need it. It's my job. But I try really hard to be as available as on this issue. When I was given this appointment by at the time Speaker Schwarzkopf, he knew that I'm a detail guy and I could roll my sleeves up pretty well to get into this, and that I would work hard to keep my colleagues informed. And there's a lot going on. I have spoken up a lot in the subcommittee, and I hope that it's been beneficial for the process, and frankly, most especially for the retirees. Okay, other comments. Okay, Kristen. Yeah. So Kristen points out that she'll be eligible for retirement at age 52. And that's because she started early and worked for the whole bunch for the state. So the challenge is, as a country, the whole thing is, we've got privatized health insurance or health coverage compared to every other advanced democracy on the globe. That's a problem. And in the U.S., we've set it up to you retire at 65, and that's where we got this thing called Medicare, and it's a great thing. But what happens when you retire before 65? Jeez, it used to be terrible before the Affordable Care Act, and you had any pre-existing conditions. You retired at 52, you were out in the cold. But now at least you can get guaranteed underwriting for health insurance at any age. So that's very good. But what do employers do? Are they responsible for paying health insurance from 52 to 102? You work 30 years, we have to pay 50 years worth of health coverage, health costs. The answer is probably yes, we do. But it's because we're in a country that doesn't address this in a comprehensive way. So it's a real challenge. Elizabeth, happy. I'm glad you're here, and all you do to share some of the updates. Certainly not too well for retirement folks. So yeah, I know I'm missing a lot. Kristen, keep in mind this is I don't have a good analogy yet for it, but picture a funnel. We're pouring. This subcommittee is looking at not everything, but almost it feels like everything. We're pouring all the stuff in the top of the funnel. Nothing's come out. We've made no decisions. That's exaggeration. We made one decision. We asked the legislature to pass Senate Bill 175 to put 1% of the budget into the budget. Going forward, they passed it both chambers. We passed it both chambers. The legislature passed it. We're waiting for the Governor Carney to sign it. So that's the one thing that's come out of this funnel. Everything else is stuck in there. And we haven't narrowed it. We haven't pulled out HRAs. We haven't pulled out Medicare Advantage only. Those things should be slam dunks. They should have been done a month ago, maybe 2 months ago. So we just keep having all this stuff on the table, and we've got 6 weeks left till the end of August. Why why does that matter? Okay, let's back up. There's a court case still underway. At some point, it's going to be decided. Okay, at some point, the state can move forward and make its next health plan ready. We're expecting that's going to be January 1st of 2025. That the current plan will stay in place currently through June 30th of next year, likely till December 31st of next year. We're going to need a new one. Well, how do you replace a new one? You bid out the next one. So you put out what's known as a request for proposal. It has to be written up in September, maybe October, put out, give the companies a month or two to submit their bids, take a month or two to decide, choose, and then tell everyone. We need to get we're an advisory subcommittee. We need to get our advice, our recommendation out end of the summer. September 1st would be great. September 30th, I'll say at the latest. We got to get that funnel unstuck. And we need to get a narrow recommendation out by September. So anyway, that's why we're working kind of feverishly at this point. And we'll see how that goes. Thank you all for joining. What are we, an hour and 11 minutes in? Please have a good rest of your day. The rain has stopped. Maybe it'll stay stopped for a bit. But again, thanks for joining, and don't hesitate to reach out. My email is at the top of the list, paul.baumbach@delaware.gov. Thank you all very much.